When we think about like taking a building apart, we usually picture a wrecking ball, right?
Oh yeah, just total blunt force.
Exactly. You smash the walls, the roof caves in, and you clear the rubble.
Yeah.
But imagine having to remove the entire first floor of a skyscraper.
The load-bearing walls, the plumbing, the electrical grid, all of it.
Yeah, all of it. While keeping the lobby totally pristine, the upper floors completely intact, and ensuring the people inside can still, go about their daily lives. A wrecking ball is useless there.
Completely useless.
You need a highly intricate, almost impossibly delicate strategy of architectural deconstruction.
And to make it even wilder, you are executing this entire deconstruction in a space no bigger than a grapefruit.
Well, just a grapefruit.
Yeah, and the electrical wires in the scenario, they control the patient's ability to feel their own face. The plumbing is a high-pressure vascular system, and the stakes are literally life and death.
Which brings us to today's mission for you, the listener. This is a deep dive into a masterclass in high-stakes, three-dimensional spatial awareness and strategic problem solving.
It really is.
We're unpacking the surgical mechanics of a major procedure called an inferior maxillectomy. We're drawing on the incredible details from the open access atlas of otolaryngology, head and neck operative surgery.
It's a massive, highly technical resource.
It is, but we are bypassing the basic anatomy to look at the sheer mechanical logic of how surgeons navigate a microscopic minefield to excise cancer. So, okay, let's unpack this. What actually is an inferior maxillectomy?
Well, it's a surgery that fundamentally alters the structural integrity of the midface. Basically, the surgeon is removing a tumor by resecting or cutting out the inferior portion of the maxilla. That's the lower part of your upper jaw.
Right.
And they're also taking the hard palate, which is the roof of the mouth.
Okay, so that sounds incredibly destructive. Why does this matter so much for the patient?
Because the precision required here is driven by two competing mandates. The first mandate is obvious, right? Oncologic control.
Meaning getting rid of the cancer.
Exactly. Removing the absolute entirety of the malignant mass with clear margins. But the secondary, equally critical mandate is preserving the patient's humanity.
Preserving their humanity, I mean, that's a heavy way to put it.
It's the truth, though. A poorly executed resection leaves a patient unable to speak clearly. They might be unable to swallow without, aspirating food right up into their nasal cavity.
Oh, wow.
Yeah, and they can suffer from massive facial collapse. So balancing that absolute destruction with functional preservation, that is what makes this procedure so incredibly complex.
Right, so before a scalpel ever even touches the skin, I'm assuming the surgeon has to deeply understand the map of this terrain.
Oh, completely. They are operating inside the midface, which is a densely packed corridor where vital systems run shoulder to shoulder.
And the visualization isn't just about knowing where things are, right? It's about understanding the immediate catastrophic consequences of like a millimeter of drift.
That's spot on. It's totally unforgiving.
It really reminds me of defusing a bomb using a highly complex 3D map. You cut the wrong wire, or in this case, the wrong vessel or nerve, and it's game over.
Yeah, and the surgical anatomy in the maxilla and paranasal sinuses is just a minefield. The boundary line for this resection often borders the floor of the anterior cranial fossa.
Wait, so the floor of the skull?
Yes. When working near the roof of the ethmoid sinuses, the surgeon is literally millimeters away from the bone shelf that holds up the frontal lobes of the brain.
That is terrifying, just millimeters.
Right, and what's fascinating here is how surgeons use specific markers, like the frontal ethmoidal suture line, as a literal road sign.
A suture line, like a seam in the bone.
Exactly. That suture is the exact anatomical seam where the frontal bone meets the ethmoid bone. And because the ethmoidal foramina, which are these little holes for blood vessels, lie directly along this line, spotting it in the surgical field serves as a hard boundary.
So it's literally a red light.
It is the biological equivalent of a red light. It dictates that they must not dissect any higher, or they risk tearing the dura mater, which causes a cerebrospinal fluid leak, or they could directly injure the brain.
Wow, and the margins get even tighter as you move toward the back of the face.
Well, oh yeah, much tighter. The posterior ethmoidal foramen sits a mere 5 to 11 millimeters away from the optic nerve.
5 millimeters, that's what, half a centimeter?
Yep, 5 millimeter margin of error. Half a centimeter of over-dissection is the difference between a successful tumor resection and permanently blinding the patient.
Unbelievable. But how can they even see something that small if there's blood everywhere?
Well, that brings us to the cascading complications of the vascular system. You simply cannot maintain a 5 millimeter visual margin if your surgical field is submerged in blood.
Right, because the maxilla gets massive blood supply from both the internal and external carotid arteries.
Exactly. Controlling this plumbing is an active, continuous mechanism throughout the surgery. Take the descending palatine artery, for example.
Right, that one routes down to the greater palatine canal and pops out directly into the hard palate.
Yes, and a surgeon can't just saw through the palate to get the tumor out. If they shear that artery with a saw, the vessel can immediately retract up into the bony canal.
Where they can't reach it.
Exactly, and it just starts pumping blood continuously into the field.
So how do they stop that from happening?
The strategy requires preemptive isolation. Before committing to the palatal bone cut, the surgeon has to identify the foramen, find the artery, and meticulously tie it off using surgical clips or sutures.
So they neutralize the plumbing before the structural demolition even begins.
Precisely, and they have to do the same thing with the angular vein near the eye. Even a minor bleed there instantly cools and obscures that microscopic visual field they need to protect the optic nerve.
Man. And along with the vascular plumbing, they're working around a highly sensitive electrical grid too, specifically the maxillary division of the trigeminal nerve, or V2.
Oh yes, the infraorbital nerve, which is a major branch of V2. It runs directly through the floor of the orbit, the eye socket, and exits the front of the maxilla to give sensation to the midface.
And the surgeon has to remove the bone directly beneath the eye without stretching or compressing or cutting that nerve.
Right, because if they damage it, the patient wakes up with a permanently numb cheek and upper lip.
Okay, so knowing this 3D map is the theoretical foundation, but transitioning from that theoretical map to the physical reality of the operating room brings us to the setup.
Yeah, things change when you're actually at the table.
And the preoperative phase relies heavily on coronal CT scans, right, to detect the tumor's limits.
Definitely, it dictates the exact trajectory. And the preparation reflects the absolute severity of the intervention. I mean, the harsh realities of patient consent alone. They have to talk about loss of teeth, facial incisions, nerve injury.
And the airway management is incredibly complex. I know they use general anesthesia, but they often opt for nasotracheal intubation.
Right, breathing through a tube in the nose just to keep the oral cavity completely unobstructed for the surgery. But in more extensive resections, they might even preemptively perform a temporary tracheostomy.
A hole directly into the windpipe. That sounds extreme.
It's a calculated safety measure, because if the surgery triggers massive soft tissue swelling, or if there's an uncontrollable hemorrhage into the throat, a standard breathing tube can become compromised. A tracheostomy secures the airway well below the surgical field.
So oxygenation is guaranteed regardless of what chaos happens in the midface.
Exactly.
Okay, with the airway secure, the surgeon has to actually access the maxilla, and this is done via something called the midfacial degloving. And here's where it gets really interesting, because elevating the soft tissues entirely off the face, a midfacial degloving, that sounds violently aggressive. Is it as brutal as it sounds? It literally translates to removing the face like a glove.
I know, the terminology is incredibly visceral, but the technique is actually a masterclass in tissue preservation.
Really? How so?
Well, historically, maxillectomy has required something called a Weber-Ferguson incision. That was a massive, full-thickness cut directly through the facial skin. It split the upper lip, ran up alongside the nose, and went right under the eye.
Oh wow, that sounds like it would be quite a scar.
Significant, permanent external scarring, plus it transects facial muscles. But a midfacial degloving completely circumvents the external skin.
Because the incision is made entirely inside the mouth,
right,
along the upper gums.
Exactly. From that intraoral incision, the surgeon elevates the soft tissue in a superior plane.
So they lift it under the periosteum, that dense membrane covering the bone.
Yes. By lifting the periosteum off the bone, the surgeon takes all the overlying muscles of facial expression, the blood vessels, the facial nerve branches, safely with the flap. They're essentially sliding the entire soft tissue mask of the midface upward in one single piece.
That's wild. So they get a wide open, perfectly illuminated view of the bare maxillary skeleton, and there's not a single external cut on the patient's face.
It's brilliant, but that upward dissection does have a strict mechanical limit. They have to stop the elevation the exact moment they encounter the infraorbital foramen.
Right, that hole where the nerve we talked about comes out.
Yeah.
Because if they blindly keep lifting the periosteum,
They will shear the infraorbital nerve right as it exits the bone. Identifying that foramen and preserving that nerve bundle that tethers the face to the skull is what prevents that permanent numbness.
got it. They also divide the hard and soft palate junction to get to the nasopharynx. So now the soft tissue envelope is safely retracted. The bone and the tumor are fully exposed. This means the procedure shifts into the deconstruction phase.
Yes, the actual removal.
And it relies on a highly choreographed sequence of strategic bone cuts or osteotomies.
And that sequence is dictated entirely by fluid dynamics and vascular control. The golden rule here is to deliberately plan your cuts so that you reserve the most vascular bloody areas for the absolute end of the resection.
Wait, I'm confused. If the tumor is right there, why not just cut the bloodiest, most tumor-dense part out first to just get it over with?
If we connect this to the bigger picture, maintaining the integrity of the surgical field is the only way to ensure those tight oncologic margins.
Vision.
Exactly. The back of the maxilla borders a massive network of veins and branches of the internal maxillary artery. If you make your first cut through the back plates, the pterygoid plates, the area floods with arterial and venous blood.
And you lose all visibility.
Completely. Trying to navigate those millimeter margins around the eye or the brain base while suctioning a massive hemorrhage is physically impossible.
So they engineer the sequence to keep the field dry. They make the front, medial, and lateral cuts first, while they can still see clearly, and save the vascular floodgates for the very final maneuver.
Right. And before doing the primary cuts, they often do an introstomy. They take a power drill or gouge and make a small window through the thin front bone of the maxilla.
Like a surgical pupil.
Exactly. The CT scan is a great digital map, but the pupil lets them look inside the sinus and physically see the tumor's exact borders. That visual confirmation tells them exactly where to make the big cuts.
And those big cuts, the osteotomies, they use sharp chisels or powered saw. They cut the lateral wall, the anterior medial wall right up to the nose, and then they do a sagittal cut right through the palate, slicing the roof of the mouth in half.
Yes, to disconnect the tumor side from the healthy side. And the final, most complex cut is the pterygomaxillary separation. The surgeon uses a specialized curved osteotome, which is like a chisel, to reach deep behind the maxilla and fracture the connection to the back plates.
And that's often a totally blind maneuver, right?
Mostly blind, yes. The surgeon relies entirely on spatial awareness, the trajectory of their instrument, and the tactile feedback, the literal feel of the bone yielding to the hammer.
Man, driving a chisel too deep back there risks hitting the internal carotid artery. It requires immense mechanical restraint.
It really does. But once those cuts are made, the maxilla is effectively disconnected from the skull base. It's only held in by some soft tissue, so the extraction phase begins.
Which relies on applied physical torque, the dramatic final step.
Yeah, the surgeon grips the mobilized bone and literally leverages it downward, fracturing the back wall and snapping the remaining bony struts to remove the specimen.
That transition from microscopic nerve dissection to macro-level physical pulling is just jarring, but necessary. And once the specimen is out, that predicted hemorrhage finally happens.
And they are ready for it. They rapidly pack the defect and then systematically identify and tie off the bleeding vessels.
So, okay, the bleeding is stopped, the tumor is completely removed, but the patient is now left with a massive structural defect. The barrier between their mouth and their nose is just gone.
Right. And the mission profile of the surgery completely flips. It transitions entirely from calculated destruction to advanced reconstructive engineering.
So it's like extreme home renovation. You've knocked out a load-bearing wall to remove the termites, and now you have to borrow wood from the living room floor to rebuild the ceiling.
That is a perfect analogy, because the objectives are incredibly demanding. They have to restore palatal integrity separating the mouth from the nose.
Because without that, the patient can't speak intelligibly, and swallowing pushes food right up to their nasal cavity.
Exactly. Second, they have to maintain mid-facial projection. They need to support the cheek and the eye, otherwise the face just collapses inward. And third, they need to lay a foundation for future dental work.
Okay, so what's in their toolkit for this rebuild?
I know the simplest fix is an obturator. Right. An obturator is a specialized prosthetic acrylic plate. It physically plugs a hole in the palate, kind of like a bulky upper denture.
But they're hard to keep in place, aren't they?
Very. Because you remove the bone on one side, the denture has nothing to clip onto. It relies on the remaining healthy teeth and some wire clasps to constantly fight gravity. Over time, that weight can loosen the healthy teeth, and it requires constant adjustments to keep a watertight seal.
So moving beyond prosthetics, surgeons use local flaps, right? Like the temporalis muscle flap.
Yeah, the temporalis flap is great. They detach that fan-shaped muscle from the side of your skull, route it under the cheekbone, and sew it into the mouth to recreate the palate.
But that's just soft tissue. It doesn't recreate the bony support, so you can't really wear dentures on a muscle flap.
Correct. Which is why, to achieve true structural reconstruction, surgeons deploy the absolute pinnacle of microvascular engineering, the free tissue transfer. Specifically, the free fibula flap.
And this is just mind-blowing to me. They literally harvest bone from the patient's lower leg to rebuild their upper jaw.
It is incredible. A second surgical team takes a segment of the fibula, the small, non-weight-bearing bone in the calf. But they don't just take the bone. They meticulously dissect out its blood supply, the peroneal artery and its veins.
So they amputate this block of bone and blood vessels from the leg, and the clock starts ticking immediately because the bone is dying without blood flow.
Exactly. The flap is transferred to the head. And using a high-powered microscope and nylon sutures that are literally finer than a human hair, the reconstructive surgeon plumbs the leg artery directly into a branch of the carotid artery in the neck.
They're grafting a 2mm artery from the leg into the neck to reestablish blood flow. That is astonishing.
And once it's perfused and alive again, they shape it. The fibula is straight, so they cut little notches into it, bend it into a horseshoe shape to mirror the jaw, and screw it into the skull base with titanium microplates.
And because it's real, living bone, it integrates permanently. Months later, the patient can actually get titanium dental implants drilled right into that leg bone in their face, snap on some crowns, and chew their food normally.
A reconstructed skeletal arch built from their own shin bone, fueled by the blood supply of their neck. It is the ultimate synthesis of oncology, structural engineering, and microvascular plumbing.
So what does this all mean? We set out today to examine the surgical mechanics of an inferior maxillectomy. We bypass the standard biology to look at the physical reality. It begins with diffusing an anatomical bond, using suture lines as hard boundaries against catastrophic nerve injury.
It really is a high-wire act.
It moves through a tissue-sparing mid-facial degloving, setting the stage for strategic bone cuts governed entirely by fluid dynamics. And it culminates in the microvascular transplantation of a leg bone to completely rebuild the midface.
I think the question for the listener is, what stands out to you? We walk past individuals every day who have undergone radical head and neck resections, and we are completely oblivious to the staggering multidisciplinary engineering that allows them to speak, eat, and breathe naturally.
We really are. It forces a complete paradigm shift in how we view anatomical architecture.
I want to leave you with a final thought to mull over. The sheer cognitive load on the surgical team is immense, translating 2D scans into a 3D mental map, executing blind bone cuts based on tactile feedback. Considering all that reliance on spatial intuition, how might the rapid advancement of 3D printed biomaterials and augmented reality headsets completely revolutionize this in the next decade?
Oh man, AR in the operating room.
Imagine wearing an AR headset projecting the exact vascular network directly onto the patient, eliminating blind maneuvers. Or instead of harvesting a leg bone, what if a 3D printed vascularized bioscaffold seated with the patient's own cells is simply plumbed into the neck? The tools of deconstruction and reconstruction are on the verge of a technological revolution.
The architectural brilliance of the procedure will remain, but the mechanics of execution are about to completely evolve. Thank you for joining us on this deep dive. Take care and we'll see you next time.